I'm absolutely delighted to be here, and thank you very much for inviting me. Thank you, Maureen, for organising such a wonderful conference again. And I've enjoyed very much seeing your wonderful city of Vancouver. I'm going to talk about circulating markers in diagnosis, which is problematic, in monitoring disease and progression of disease, in monitoring treatment, in checking for recurrence, and all of those three middle things really come together to some extent, and as prognostic indicators. I run a routine lab for the diagnosis of neuroendocrine tumours in the UK. We have two labs, one in Hammersmith in London and one in Belfast in Northern Ireland. So a lot of my research is actually very related to diagnosis, monitoring disease and prognosis, very patient orientated. And it might be looked on sometimes more as audit than research, although I do some developmental research as well. So we have some options. We can look at circulating markers, or we could use radiology for diagnosis and following disease, or we could use tissue pathology. And just very quickly, I'm going to say radiology is wonderful. It has come on so much in the last lot of years, but there are some limitations. And that is that the size of the tumour has to be really quite large. And I know that many of you in this room would feel that if you had a tumour or many tumours in the liver of 1.5 centimetres, you'd be very concerned because the radiologists would be saying they're not seeing anything. And problems with repeating scans. Now, scans are very expensive, and there's a dose of radiation with some of the scans that we choose to use. So you can't have these repeated monthly or 6 monthly sometimes, so we have to think of other easier ways sometimes to follow disease. With tissue pathology, you have a biopsy or you have a sample from surgery. That's one point in time. And this is a very nice example, a little circle of brown cells, or very quickly dividing cells stained with Ki67, and that's a blood vessel. And you'll see one or two other scattered cells about the slide, and they're showing neuroendocrine tumour cells. But the limitations there, we have a single piece of tissue at a single point in time. We have a problem with repeating a biopsy frequently because nobody thinks that's very ethical, probably. And is the section representative within that tumour? So are we getting the front edge, the growing edge of the tumour? Are we getting the middle? Are we getting a bit that's more indolent? And are the tumours all the same? If there are many, many tumours scattered about the liver, are they all the same? So although we have some problems with circulating markers, they're one of the good range of tools that we can use for diagnosis, for monitoring disease, for monitoring treatment, and for prognosis. Well, the advantages are we can take tests frequently, and in some patients we will be measuring their circulating markers once a month. They're non-invasive comparatively. Sensitivity can be very good, and there's a relative low cost, much, much cheaper than scans. And there are limitations that there are false positives, there are false negatives, and sensitivity, again, sometimes can be not good enough. So to get back to Chromogranin A, which is always very interesting, there are many false positives. Now, I've just gone back and done an audit of 3,500 patients, and 16% of those patients had a Chromogranin A in the assay that we use of over 1,000. That's really high. And one of those 16%, it was for another reason. So the very, very high ones are almost invariably tumours. But the kit provider there says that the reference range would be 0 to 30, and anything between 30 and 100, and that's more or less 3 times the reference range. I'm thinking that I'm not getting over-anxious about unless there's additional evidence that there's disease. So there's a lot of patients in between. So the false positives come from renal impairment, and a lot of folk who've had some treatment, a lot of folk who are elderly will have renal impairment, and all of the peptides, including Chromogranin A, will be raised. If there's no acid in the stomach, Chromogranin A will be raised as well, and that's because of atrophic gastritis if you have pernicious anemia, autoimmune atrophic gastritis, or if you're on proton pump inhibitors. And I don't know about this side of the Atlantic, but every other person in the UK is taking proton pump inhibitors, and they're available over the shelf. And they really can put Chromogranin A up quite a lot. I'm just showing you 10 patients here that were taking that were taking proton pump inhibitors, and we withdrew that for a week and took a second sample, and you can see that the Chromogranin A's were really raised and came down to within the normal range. And you can see that some were really very much raised when I'm saying that I'm worrying about anybody with the chromogranin A above 100. And here's one patient looking at the chromogranin A and their gastrin in red, and they start off with a chromogranin A of 1200, really into the tumour range, way big time. We took them off their proton pump inhibitors down to nothing. We put them back on again, and the chromogranin A rose almost immediately, and we put them eventually onto proton H2 antagonist drugs, and it was much easier to assess what the chromogranin A is. So we do have serious false positives. And my message is that chromogranin A is the only general circulating marker available. It's not as good for diagnosis, and it's not wonderful, but it's the best we have. And I think along with the other tools that we have, it is really worth using. It's really worth using because it's not so good for diagnosis, but it's very good for monitoring disease once we know that a patient has a tumour. It's very good for following treatment, and it's very good for monitoring recurrence if there's a nice long phase when the tumour is not active. And it can also be used as a prognostic indicator. We know we've seen slides like this morning, and we know we've got lots of different tumours, and I'm just going to very briefly say that in lots of those different tumours from different areas, they're going to secrete other peptides or amines or markers as well as chromogranin A, and sometimes these can be very useful. So for an insulinoma, we might not really be getting a lot of information from chromogranin A because, in fact, the majority of insulinomas are not even malignant, and if they're not malignant, then we won't get a raised chromogranin A. So we're looking at insulin or proinsulin or C-peptide. For something like a vipoma, we want to follow the VIP. The chromogranin A we may follow as well, but really what we want to know is what that tumour is continuing to put out into the circulation. And for the tumours that are spread along the GI tract, we can use a lot of circulating markers to help us there. And I'm just going to take an example of looking at the stomach tumours. There are three sorts of tumours, neuroendocrine tumours, that we can have in the stomach. We call them type 1, type 2, and type 3, being very original. And the first two types are one associated with Zolnjerelsen syndrome, the other associated with the stomach that doesn't have any acid, and they secrete chromogranin A and gastrin. So we're expecting those to be quite high. The third one, the chromogranin A, will be up, but not the gastrin. So things can be quite useful from that point of view. Quite a lot of my talk now is going to be about tumours that are in the jejunum, the ileum, and the proximal colon, what we have traditionally called the midgut carcinoids. So we're going to look at, somebody was asking a question and I helped answer it, and I said wait and come to the afternoon session about circulating markers and response to treatment. And we see that if we give a single dose of a somatostatin analogue, and we look at several of the markers, and here we're looking at pancreastatin, which is a little bit of chromogranin A and has been used by many groups as a surrogate marker really for chromogranin A. We're looking at pancreatic polypeptide, and we're looking at one of the tachykinins, a neurokinin A, and we see that just with a single dose of somatostatin analogue, we see a nice suppression, not always into the normal range, but a very significant suppression of the circulating markers. And here is an example over a little bit longer time with 12 patients. These patients have midgut carcinoid tumours, and their neurokinin A, the tachykinin that we like to measure in Belfast, shows a really nice suppression just with that one dose. So the question that you ask, are the circulating markers and is chromogranin A suppressed by treatment? And the answer to that is yes, but not just always. We look at a group of patients here, and we have 53 patients who went on to long-acting somatostatin analogues. So they'd had their original little bit of treatment, whatever that was, hopefully surgery, and maybe something more interventional as well to do with liver secondary disease. And then they've gone on to somatostatin analogues as maintenance treatment. And we can see that, in fact, 3/4 of the patients, more than that, are the red lines. As we follow them for 2 years, their chromogranin A has remained very low and very controlled, and the disease has been controlled. And therefore, the peptides that are causing problems with midgut and that are life-threatening to some extent are being controlled for quite a long period of time. We notice, however, that some patients, and particularly those that start off with high chromogranin A's, and even though we've maybe had surgery and we've maybe had a couple of other interventions as well, they are not maintained on somatostatin analogues alone, so we have to quite rapidly think of other treatments. This is a really good indication that treatment is not going well. We're jumping here from the midgut carcinoid to a single patient with a gastrinoma, and we can see very nicely following the gastrin that the gastrin was really high to begin with, nearly 8,000 nanograms per litre. The tumour was resected, and that was followed by streptozotocin and 5-fluorouracil for 3 cycles, and the gastrin came right away down and was controlled for almost 2 years. And then after that we changed and decided to use hepatic artery embolization. And this patient has had several other treatments since then, so we can monitor what the response of that tumour is in that patient with different sorts of interventions looking at the gastrin. And I would suggest when we have a different marker, often gastrin for gastrinoma, serotonin for the midgut carcinoids, or we prefer to use the tachykinin, neurokinin A, then they are more sensitive often than chromogranin A itself. This is another very nice example, and this is not only an example of monitoring treatment, but it's a really beautiful slide in relation to prognosis. This is a lady, a single patient who presented in the year 2000 with a midgut carcinoid and a very high tachykinin. And somatostatin analogues, as you'll see, with continuing increasing doses didn't control the secretion from that tumour. But we added in alpha interferon, and I think my arrows have shifted slightly to the right there. The interferon should be a little bit over to the left. And her tachykines have come down. Her disease was controlled for 7 years. And only just recently she's undergoing lutetium treatment in London. So we have followed that very well. Why do we want prognostic indicators? Well, we want prognostic indicators, and we want them to be simple and easy for measurement, because some tumours don't move on. They just sit fairly statically and are very indolent for a long period of time. And nobody here wants to undergo really ferocious treatment if the tumour is indolent. If we've treated it to some extent up front, and it's just sitting there not doing anything and almost not visible. So we don't want to go in and do anything too interventional in those sort of situations. But in some patients, the tumour progresses very quickly, and this is another scan, an octreotide scintigraphy, taken after 6 months in the same patients, and you can see that the disease has spread enormously. We don't want to miss that window of opportunity. For this patient, there was a short period when we could really intervene and do something, and we didn't want to be sitting and watching and waiting. We want prognostic indicators that will indicate that this will happen. Now, what prognostic indicators have there been in the past? And if we look around, I'm more likely to die in the next 5 years than somebody in this room who is 25 years old, purely because I'm much older. With metastatic disease, it depends on whether there's local or distant, or the number of metastases, whether it's in the liver, and the volume of metastases. And all of these things have been linked in the literature to prognosis. And we've talked a lot about Ki67 this morning. And if Ki67 is less than 1, or if Ki67 is more than 20, then those two prognoses are going to be different. The size of the tumour, the size of the primary tumour, or the site of the primary tumour. In general, pancreatic tumours, when they're malignant, will not do as well as those in the midgut, but not absolutely. But I've been looking at circulating chromogranin A and circulating pancreastatin, and also in the midgut in particular, we've been looking at serotonin, urinary 5-HIA, and the tachykinins. If we look at chromogranin A as a prognostic indicator, we're looking here at 56 patients, and these patients all have tumours of the midgut. And we're seeing that these were the very first samples that were taken. So this is the first time this patient had a chromogranin A taken. Not maybe absolutely at the time of point of diagnosis, but close to that, before intervention. And if the chromogranin A was low in the assay that we used in Belfast, then survival at 3 years was at 100% in this group. And If the chromogranin A was somewhere in the middle, then survival was about 70%. But if chromogranin A was in the very upper range, and this is looking in a retrospective study, so we don't know what was done to these patients after that, and we're looking back into history, then the prognosis was poor. Chromogranin A is a big molecule, and we've had lots of difficulty with measuring the whole thing, but quite often people in the past have measured pancreastatin, and quite often people in the future or in the present have thought that it's quite a good thing to measure as well. If you make an assay to pancreastatin and you measure the middle of pancreastatin, it's more or less going to cross-react with the whole of the chromogranin A molecule. So you'll get fairly similar results. But if you use an assay that measures either end, so in other words, you have to have free pancreastatin in the circulation, and you're not going to measure it in the whole molecule, you're only going to measure it when it's broken up and it's circulating free, then that can give quite interesting results. And we've worked that out to be a very good prognostic indicator. I want you to look at the red data here, and this is two groups of patients, and they have presented at the clinic, and they have had similar pancreastatin concentrations, the red on the left and the blue on the left, the pre-treatment. In fact, if anything, the red patients have had slightly higher pancreastatin to start off with. They've gone on to somatostatin analog treatment, and in so doing, some have responded very well. We couldn't predict who was going to respond well and who didn't, but some haven't responded well. And those that didn't respond well, and this was a retrospective study again, have not survived. So the 1-year survival for the responders to somatostatin analogues was very good, and the 3-year survival also, but for those that didn't respond to somatostatin analogues and their markers continued to rise, this was a bad prognostic indicator. And I just really want to say one more little piece, and I hope you'll let me say this because this is quite interesting. In Belfast, we've done a lot of work with the tachykinins. We found that neurokinin A is an independent prognostic indicator. It doesn't really depend on the number of tumours or the volume of tumours or where they are if it's a mid-gut carcinoid. Only secreted by mid-gut carcinoids, so it's very, very specific. That makes it very interesting. And if patients present on their first time at a hospital, and this is again in a retrospective study with a neurokinin A greater than 50, then less than 50, then their prognosis is very good and their survival is very good at 3 years. And this was in a retrospective study, as I say, where we were less interventional. If the neurokinin A was greater than 50, survival was poor. If we look at that on the survival chart, you can see the heavy line are those that had the low neurokinin A's, and the dotted line those that had a high neurokinin A. So it's an independent prognostic indicator. It's letting us know how the patients are going to survive if we take a sample the first day they come to hospital. But the most exciting thing about it was that the most recent neurokinin A overrides the initial one. So if we can change the neurokinin A concentration in the blood, that gives us a new prognosis. If it goes up, it's going to get worse. If it comes down, it's going to get better. And you saw in that lady that I said went on to interferon and has been with us for 7 years on interferon, we would have said her prognosis was probably between 6 months and 2 years. And she's been on interferon for 7 years. Her tachykinins have stayed really low. So if we can lower the tachykinins, can we improve prognosis? And the answer to that is yes. And this is the patients with the quite low tachykinins in the white line. And with our prospective study, where we have tried to keep those tachykinins down at all times by intervention, and sometimes intervention before the symptoms have returned, then the prognosis has improved. And also for the patients, and these are rather faint, I'm sorry about that, for the patients that were doing poorly, who had the high tachykinins at presentation, if we work hard on keeping those down and lowering them, we're finding prognosis is vastly improved. So this is very exciting. With new treatments, we have new ideas, and we'll maybe have more targeted therapies. We can measure things there are several pathways that neuroendocrine tumours may follow. similar to other cancers, sometimes not just so independent, and we can maybe find markers that are related to those. When we think of angiogenesis, these are very vascular tumours, lots of blood supply. So if we look at some of the markers of angiogenesis, maybe this would be very interesting. And this would be more geared to some patients rather than all patients, even in the single group. So chromogranin A is the best general marker. That's because it's the only one. But it's quite good for following patients. It's not so good for diagnosing them. We have lots of problems with false positives and false negatives, more with false positives. But we also have a range of good specific markers. It's a very good method for following disease, and we have other very good methods for following disease with the specific markers. And we have very good prognostic indicators for some of the tumour types. And we can take a blood sample and tell you a lot about what's happening with your disease now. And it's easy. It should be repeated often. There's no point in doing it once at the beginning of your diagnosis. It should be done frequently to see how things are progressing. Thank you.